Sure. So we recently published a review entitled Navigating Ongoing Challenges in GI Stromal Tumors. This was published as part of the ASCO annual meeting education book. The review was really developed as a companion to an educational session as part of the ASCO annual meeting. And that education session was again really focused on current challenges in GIST. There are three main sections to the review. The first is talking about the role of adjuvant therapy in localized GIST. The second was talking about current standards and development of kinase inhibitors in GIST. And the third was talking about management of GISTs which do not harbor an activating mutation in either KIT or p2 receptor alpha. It's a really good question because it's one of the topics that we discuss in the review, as well as is really well addressed in the educational session by my colleague, Dr. Yuensu. There are many different stratification systems to define risk in localized GIST. The three main drivers that are included in most of those systems are tumor size, tumor location, as well as mitotic rate. And we know that tumors that occur in the small intestine, for example, are at higher risk than tumors that occur in the stomach. Tumors with a high mitotic rate are at higher risk than tumors with a low mitotic rate. And and we know that primary resection is critical. I think taking these into consideration really helps us to make the decision about who to treat. High-risk tumors are typically large, maybe in the small bowel, but high risk also can occur in the stomach. And they also have a high mitotic rate, which for GIST is defined as greater than 5 mitoses per 5 millimeters squared. Dr. Yoensu actually has published some really nice papers also looking at some novel heat maps, because so much of the current risk stratification is very category based, but risk is likely more is not so binary. Like it's likely more of a continuum. And I think looking at some of these newer risk tools can be very helpful when meeting with the patient to talk about use. But in general, if the tumor is large, if the tumor is in determined to be high risk based on location and in coordination with the size as well as the mitotic rate, those are the patients that are typically offered imatinib. So kinase inhibitors are really the backbone, as you say, of treatment in GIST, and kinase inhibitors that are directed against KIT or p2 receptor alpha, because those are the driver mutations in the vast majority of GIST. What we know is that with subsequent post-imatinib, as one gets through subsequent lines of therapy, the primary mechanism of resistance to KIT-directed TKIs is the development of secondary KIT mutations, which are resistant to imatinib. We know that these resistance mutations occur in a non-random pattern, either clustered in the activation loop, which is in exons 17 and 18 of KIT, or in the ATP binding pocket, which is exons 13 and 14. We know that subsequent lines of therapy that are currently FDA approved for GIST have differences in activity against these resistance mutations. Most of that actually has been determined after the drugs were approved. So all of these drugs, sunitinib, regorafenib, ripretinib, which are second, third, and fourth line approvals respectively in advanced GIST, were all approved in a mutation agnostic fashion. So current guidelines recommend treatment as per FDA approvals without specific consideration of secondary mutations. However, we know that response to treatment and duration of response to treatment can vary based on those mutations. The challenge, however, is that most of the studies that have looked at using mutation directed treatment are either retrospective or have used different methodologies to identify those resistance mutations. Some use tumor biopsy, some use ctDNA. And what can be really hard is that in an individual patient with GIST, you can have multiple secondary resistance mutations present, but they may not be easily identified depending on what technology is used to try to identify those mutations. So in our clinical practice, we gain the information around secondary mutations, often from ctDNA. We typically will still treat based on the standard first, second, third, fourth line FDA-approved treatments. But the secondary mutations can be helpful for clinical trial participation, for example, and I suspect would be helpful as future drugs become approved in this space. So this is an area that we really need to continue to learn more about and to match therapies with mutations in prospective trials to optimize outcomes. Sure. So sunitinib, for example, is a very potent inhibitor of the most common primary KIT mutations. So those are exon 9 and exon 11, but also very potent inhibitor against secondary resistance mutations in the ATP binding pocket of KIT. So that's exon 13 and 14. Sunitinib has very little activity in exon 17 secondary resistance mutations. There was a study published that compared sunitinib to ripretinib in the second line, for example, and it demonstrated that patients who were randomized to sunitinib who had secondary resistance mutations in the ATP binding pocket did very, very well compared to those who were randomized to ripretinib. Alternatively, patients randomized to ripretinib that had secondary resistance mutations in the activation loop, meaning exons 17 and 18, did much better with ripretinib than sunitinib. Unfortunately, the study was powered on the intention to treat population, so the entire group, and it was a negative study. But these subpopulations have really raised the question as to whether one can do ctDNA, for example, in the second line and try to optimize the choice for second line therapy. There's an ongoing clinical trial that is specifically designed to address that. It's called the INSIGHT trial, where patients who have ctDNA positive for exon 11 plus exon 17 or 18 resistance mutations. And those folks are randomized to either sunitinib or ripretinib to see if this retrospective ad hoc observation does indeed lead to improved oncologic outcomes when studied in a prospective manner. So I think that's very important. I think another really important thing to consider when thinking about therapeutic choice and mutations is when you think about primary mutations in GIST. So as I mentioned, the vast majority of GIST will have driver mutations in KIT exon 11 or a primary mutation in exon 9 in both of KIT. However, there's this very small subset of GIST that have a primary driver mutation in PDGF receptor alpha D842V, which is inherently resistant to imatinib. And there is a drug called avapritinib, which is FDA approved specifically for patients with this mutation, which is in exon 18 of PDGF receptor alpha. In those patients, avapritinib is the first line therapy, actually the any line therapy that is FDA approved for that unique patient group. So I think understanding both primary resistance is very important for initial selection of treatment. Vast majority of patients will receive imatinib, but important subsets should have a different approach. And then secondary resistance mutations is really an active area of ongoing prospective clinical trials to help understand whether specific matching of therapeutics to secondary mutations will improve long-term outcomes. So importantly, as I just mentioned, that the majority of GISTs do have mutations in one of these genes, primarily in KIT. And all the approved therapies that we think of in GIST, first line imatinib, second line sunitinib, third line regorafenib, fourth line ripretinib, are all really directed against primary KIT mutant GIST. There are subsets, however, that don't have this or have a unique um, kinase inhibitor mutation that are not sensitive to those drugs. So PDGF receptor alpha D842V is a very specific mutation where avapritinib is the drug of choice for that patient population. But other non-KIT, non-PDGF receptor alpha mutant GISTs are important to note. One is a subset that we call SDH deficient GIST. SDH deficient GIST is defined by an alteration in one of the subunits of the succinate dehydrogenase complex, so SDH A, B, C, or D. Those SDH deficient GISTs are super important to note because they primarily occur in young people and they're primarily gastric. They can be multifocal in the stomach and they can spread to lymph nodes, all of which are pretty unique to that subset of GIST. The other important thing about SDH deficient GIST is that a subset of patients with SDH deficient GIST will actually have a germline alteration in one of the SDH subunits, and that can have implications for screening for other neoplasms, specifically paraganglioma. So it's very important to understand that group of patients. Those patients are typically considered non-responsive to imatinib. So first-line therapy is likely another broader spectrum kinase inhibitor, such as sunitinib. Regorafenib might have activity, but there are other ongoing clinical trials looking at more novel approaches to treat this particular disease and its unique biology. Some of those include FGFR inhibitors, some include actually more traditional chemotherapy. So these are all things that will be coming up in the literature, I suspect, that really are important to acknowledge as a different disease. And then there's other groups of patients with non-KIT, non-PDGF receptor alpha mutant GIST, and those include GISTs that may be driven by alterations in NF1, so neurofibromatosis associated GISTs. Some of those tumors are really, really indolent. Others can be more aggressive, but they tend to have a different natural history. They're not responsive to imatinib or other KIT inhibitors because KIT doesn't drive the disease. It's being driven by a different alteration. Other small subsets of GIST that fall into this category include GISTs that have alterations in BRAF. And there are some studies that suggest BRAF inhibitors can be useful. So again, for GIST in general, understanding the primary molecular landscape of each patient the tumor in each patient is really important, because although the vast majority are KIT driven, those that are not may have very different treatment approaches as well as different natural histories.